Good afternoon, everyone. Welcome to this joint committee session of the Government Operations and Fiscal Policy and our HHS, a Health and Human Services Committee. We have two supplementals that we will be talking about today. The first is supplemental appropriation 25-34 to the FY25 operating budget. This is for the Care for Kids program. The amount is $332,000, and it is for a Section G designation of entities for non-competitive contract award status, the Primary Care Coalition, and I'm going to turn it over to Ms. Clemens Johnson to walk us through it.
Good afternoon, and thank you. As noted, this supplemental is supporting the Care for Kids program. It will support direct medical services in primary care, behavioral health, specialty dental, and pharmacy services. Care for Kids is a long-standing program. When I was doing the report, I saw that it was started in 1992, so I thought I would add that. So they've been operating the program for about 32 years. In your packet, I included programmatic data so that you have some context for the program and how the enrollment has been going. In the past 5 years, the program has doubled in the terms of the number of children that has been served, almost 11,000 in FY24. I did want to note that I did not include in the packet that there hasn't been any funding added to the program since FY22. So in the past 3 years, the number of enrollees has increased by 38%, or 3,000 children, and the program has been working within its current budget and absorbing those children and providing them services. There is additional data just to give some demographics about where the children live, and the FPL of most of the participants, which is fairly low, over 50%, and over 50% of the children enrolled and families enrolled have incomes of 100% of FPL or less. Regarding the request, the split of funding is shared in your packet on page 3. I did want to call attention that there was a budget shortfall in FY24. So the department is currently working through the claims process, and that claim was for $335,000. I provided that information to also help support the budget detail in terms of the shortfall. So when we look at the percentage of the budget expended, it would appear to be that they are on target to spend their budget as, or to spend within their budget. But when we delve into the details, the program is likely to expend the budget over the course of the next 6 months as enrollment grows. I also talked to the program staff, and there are invoices that haven't been received. So the data and the numbers are, the budget is not really reflecting the shortfall as of right now, but there are truly extenuating circumstances that are affecting what is reported. So if there are any questions, I can answer them. Thank you.
Great. Dr. Asher, did you want to add anything?
That was a great recap, so I don't think I have anything else to add. Thank you.
Great. Well, thank you very much. I'll turn it over first to the chair of HHS.
Thank you, Madam President. So just an editorial here. The Care for Kids program is, I think, one of the most important initiatives that the county has initiated in the last 32 years. And we know that it has helped tens of thousands of children during that time. And it could not be more important than it is right now, given what we know will be coming over these next several years and who will be targeted. We in Montgomery County have always felt it's not just a moral responsibility to address the needs, particularly the health needs of our most vulnerable populations, but it's also a public health imperative that we do that. So I enthusiastically support this particular appropriation, acknowledging there's probably going to be more needed, given what we anticipate coming down the pike. So thank you to the Primary Care Coalition for your tremendous leadership, and we are fortunate to have such an incredibly strong organization here within our community, and of course to our colleagues and friends in HHS for continuing their usual leadership. We truly appreciate it. So I'd like to move that we support this appropriation.
All right, we have a motion and a second, and I just want to echo. Yes, yeah, go ahead.
I was about to push the wrong button. It's like moving from one side to the other.
Yeah.
Makes you not recognize where your buttons are supposed to be. I did want to ask, though, trying to understand what went wrong with where the claim process got upended. And I just wanted to have you unpack that a little bit, because everybody's right. This is a vital program. It serves residents in need across the county. Our pediatric population, like nearly evenly split, a third, all throughout the county. But just sort of wanted to understand the logistical challenges that were there with the FY24 budget gap.
Yes, thank you for that question. I think as it transitioned to around about the third quarter of FY24 is when we began to notice that we would experience a potential budget shortfall. And so we had conversations internally amongst DHHS about different options to secure a supplemental. And based on the timing in the fiscal year, we didn't think we would be able to move a supplemental through in enough time in order to appropriate those funds. And so because we didn't want to run out of funds by the end of the fiscal year, we decided that we would just instruct the vendor to continue to provide services so we would not stop services, and that we would pursue a claim process at the end of the fiscal year in order to ensure that they get paid. Everyone was on the same page, the Vendor Primary Care Coalition, DHHS, and the program. So I think it was just maybe like a strategic decision as to how we decided to continue to ensure that we provided services, but we also will ensure we had the funding at a later time.
And by pursuing the claim process, by doing that, and my notes in here say that you all are working with the contractor to prevent a similar claim, and we're here now having this conversation. Just sort of what lessons were learned from taking that approach back then, as we sit here now in the beginning of the third quarter of FY25.
So this is an example of one of those lessons being learned. Us more tactically monitoring monthly utilization, monitoring projections, asking for that data updated on a monthly basis. I think some of the things that we also are doing is making sure that providers submit their claims within a 90-day period that is allotted of them, so that we can ensure that we have the most reflected numbers when we do update the projections. And then another thing that we're really focusing on is maximizing our wellness centers at school-based health and wellness centers, so that we can, more of our patients can be seen in the school-based health and wellness center instead of the private providers, which this funding will be directly going to the community providers where we reimburse for services.
Great. Thank you so much.
Great, thank you. Councilmember Sales, did you want to add?
Yes, I just had a quick question. Thank you again for the report. I'm in total agreement that we need to ensure that our most vulnerable children need access to quality care. The materials mentioned approximately 12,000 children would be enrolled. Is that total enrollment over the course of this fiscal year, or in addition to current enrollment, you're anticipating 12,000 more?
That's total enrollment over the fiscal year.
Okay. And are we seeing an influx of enrollment based on children being removed from another plan, newborns, or residents moving into the county? Do we know where these numbers are?
Care for Kids growth has been primarily attributed to children arriving into Montgomery County, children who may be also designated as unaccompanied minors or children, is typically where we have seen a spike in the growth in our Care for Kids enrollment over the previous couple years.
Okay, thank you.
Councilmember Friesen?
Yes, thank you. First of all, appreciate all the comments of colleagues and questions up to this point. I want to echo the comments made by Chair Albornoz in particular about how important Care for Kids is as a program, and a source of pride as it should be for Montgomery County, and the way that we are layering on those layers of mesh in the social safety net, and really driving public-private partnerships in a really thoughtful way. I think we were ahead of the curve. Fortunately, because COVID really exposed the need for these deep public-private partnerships where government doesn't really know where to go, and residents oftentimes don't really want to come to government for a variety of different reasons, and having the entry point be a government partner that is trusted in providing quality services, but not necessarily a county government building or a county government facility matters, and it helps and allows us to deliver services and reach people in ways that we otherwise wouldn't be able to reach, in places where we wouldn't otherwise be able to reach, on their terms, on their turf, in their language, as we frequently say. And the Primary Care Coalition has been such an important part of that, and want to express my and all of our appreciation for that work, as well as our public health team. I did want to ask the question, once we address this issue, there are a number of longstanding challenges in these services and the financial sustainability of these services. This is an example of one that wasn't part of the budget process. This is a reflection, to the point that we heard earlier, of a higher level of demand. I'm not sure that that is new to July 1st to now. I think that was happening well before that. So I'm very much in support of this. I will note that this is not the most sustainable way for us to be budgeting for these services moving forward, and that was very much in keeping with Councilmember Lukey's line of questioning, which I very much agree with. Both can be true. Chair Albernaz's point that we need these services now more than ever, and that we're supportive of it, but that this is not how we prefer to do it, and it's not a sustainable model for moving forward. So assuming that we support this today, that the full council moves forward with this, what is the plan for moving forward? Because we're now in really the kind of end stages of the planning process for next year's budget for the subsequent fiscal year. What is the plan for that moving forward, and for the out years, for how we address these additional needs and how we're going to continue to deliver these services in a way that won't require special appropriations, we hope, moving forward?
Yes, so thank you for that question, and we agree. We would love to not have to fund the program based off of special appropriations. It's a lot of work to pull the packages together, but we also want to make sure we're being good financial stewards of the county's money. We actually did have a budget item in the budget last year to address the increased enrollment in FY24 for Care for Kids. That, I know it was a tough budget year and lots of things weren't funded. That was one of the things that wasn't funded. So in this year's as we look at the FY26 requests, we will have considered the increased enrollment growth, and in proposals that we've made, ultimately the county executive has the final decision there, but we are taking account of that so that we're not in a situation where we have to run the program based off of supplemental funding, and we can just get a budget that's actually going to reflect the need, and we can have continuity of operations.
Great. Okay. Well, I appreciate it, and very much supportive of this and supportive of the work, and really appreciate all of the efforts, and will agree that these are services, unfortunately, that we're going to need more now than ever before, and just want to, again, express our appreciation. I think that the partnerships that we have allow us to deliver services in a cheaper, more effective way than we otherwise would be able to do through county government alone. And so I think really leaning into these partnerships more than we even have before are going to be really helpful and really important moving forward. So with that, I'll yield back.
Thank you. And I'll say, just to pick up on this last point about budgeting, this is the very reason why we started having these joint committee hearings on supplemental, so that we could have a conversation about when these things are coming to us outside of the budget process, and understand that. And I know it's a lot of work, and I really appreciate the work you all did to pull this together, because, as my colleagues say, I won't reiterate it, but I guess I will, the importance of this program and the work that you all are doing. Actually, last week, myself and our team was updated on some of the work that the Primary Care Coalition is doing, specifically in the behavioral health field. And I know that while the the enrollment in these programs has been going up for a while, that you and a number of other providers who we've heard from since the November election, as Chair Albanaz has said, has seen an increase in need, especially among our younger people, increases in behavioral health needs and anxiety and other things in that, as we are approaching later this month and the upcoming years are likely to increase as well. So we appreciate the work you all are doing and look forward to supporting it, and then having conversations when we're in the budget of how we make sure that we're budgeting for that appropriately in the year to come. So with that, all in favor of this recommending the supplemental to the full council, please raise your hand, and that is unanimous of the two committees. The next item is supplemental appropriation 25-35 to the FY25 operating budget. Again, this is to the Department of Health and Human Services. This is for infrastructure positions in the amount of $189,000, $189,000 and $87,000. The source is general undesignated funds. I will turn it over to Ms. Clemens Johnson again to walk through.
Okay, sounds good. So this supplemental is supporting 11 infrastructure positions within DHHS. As background in your packet, I included detail that this was something that was proposed in the county executive's budget. The HHS committee actually had 2 work sessions where we discussed the positions and the detail behind it. So if I go through the packet, so the request was for 11 new positions. 6 of the positions are directly attached to revenue generating activities, specifically billing Medicaid, and 5 are not. So the HHS committee at the time decided to group positions. And so group 1, of course, was priority down the group 1 to group 2, group 3, and group 4. The committee at the time prioritized the positions directly attached to revenue generation that would be in the COO's office. So this supplemental is a similar request, except for there's a change in 2 positions. They removed the program specialist position in planning, accountability, and customer service, and the office service coordinator in the child and adolescent services. And they did replace those positions with 2 school health nurse managers. And DHHS is prioritizing those positions based on the increase in school health staff related to community schools. So your packet details the positions and provides a description. I did not get get the cost of each position, but they are using this supplemental appropriation to start the personnel and bring them on board for the total cost of $189,000. So if there's any other questions, please, I'm available to answer.
Yeah, I think this one we're going to have more questions on this item because this was discussed during the budget last year during our reconciliation. I guess I'd like to start us off and ask why we're getting this request now and it doesn't wait for the budget process to move forward when we get the county exec's budget again this year.
So 2 things. One, in order for us to actually start getting revenues, we need positions in place. If we wait until the FY26 to start, it will take generally 3 to 6 months to hire them, and then we lost all that revenue. So I would like to say, prior to answering additional questions, that I appreciate everyone's excitement and support of the previous supplemental we just had. That can't happen without contract managers and PAAs, front desk staff, and all the other people in the infrastructure of HHS to be able to make that happen. So it's exciting to be able to talk about increasing programs for children who need healthcare. It's a lot less exciting to talk about hiring accountants, but they're equally important. And so I hope that we can support the people who are doing the work to help the HHS programs actually come to fruition.
Yes, I very much appreciate that. I think our questions will probably be more around the timing of things. And in the packet, it did say that these positions will, is expecting that the cost for these positions will be fully offset by the additional Medicaid and federal funds participation revenue generated by the billing activities. So is that for all 11 of the positions being requested?
It is, yes.
It is.
Yep.
Okay, and so in terms of moving forward, do you anticipate when we do get the county exec's budget, if we move forward with this supplemental, what does that mean then for committing ourselves to budget for HHS in FY26?
So these positions will continue into FY26, knowing that, and we will also, to offset that, increase our revenues for FY26 to continue to pay for this. So it will, we anticipate by putting them in place now to hire them as quickly as possible. We do prioritize hiring the 6 revenue generating positions first, in addition to recruiting for the others as well. But that we should be able to hit the ground running pretty quickly at the beginning of the fiscal year to be able to start collecting that revenue and paying for these positions.
Okay, first I'll turn it over to the chair of the HHS committee.
Thank you. So I appreciate Council President Stewart's questions, and these came up through the process last time around, and as was mentioned previously, difficult decisions had to be made. And of course, we funded to a significant extent the request of our school system, which made it difficult to be able to support all of the other recommendations that the executive had moved forward. So I want to acknowledge a couple of things. We've got some friends in the audience who represent our African American Health Program who are here in support of this specific appropriation, in part because they and our other minority health initiatives and programs know how important and integral these central office administrators are to be able to carry out their work as well. And so, Mr. Hodge, in addition to the functions of helping to ensure that we are reimbursed, this will also, I believe, help with other capacity issues within HHS. But could you just elaborate on that a little bit? And we've had extensive conversations in committee about the central administrative challenges that HHS has faced, especially the last few years since COVID. But can you talk a little bit more about those for my colleagues in the GO committee as well?
Sure. So when looking at the infrastructure positions last year, kind of this time last year when we were proposing them to the county executive, we understood that needing to increase our revenues was very important. The only way to do that is for us to bill insurance companies. We are in the process of creating MOUs with our MCOs who provide services, insurance services in our county, and able to for us to be able to bill them. We cannot. We see clients now. We bill the insurance companies and get $0 back because we are considered not in-network providers, and so they are under no obligation to reimburse us for that. And so we continue to see them, but we don't get the money back from it. The positions that we created that are revenue generating, these 6 that we put in place, are front desk people who can collect that billing information. It's an accountant who can work directly with our clearinghouse that sends the claims to the insurance companies, and a social worker who can also bill for services. And so those were important. That, in our anticipation, brings in more money than what would cost for those 6 positions. So we have other needs. One is for a program manager that can do intensive case teaming. We have many clients who are seen by multiple programs across HHS. Right now, it's very siloed. We don't have somebody who can kind of do that intensive teaming, who can bring together the different case managers and providers, social workers, and others to talk about that family, to talk about that individual, and to better provide care and get better outcomes for them. Because that intensive case teaming, there is nobody to coordinate that right now. We have, as you know, have been receiving lots of money from the state for Blueprint that has created a huge number of community schools. One of the Blueprint requirements is that a nurse be dedicated to a community school. And so our model of having one nurse for every 2 or 3 schools doesn't work when you're required to have one dedicated nurse in elementary school. So we've had to grow the number of nurses that we have quite quickly, but we don't have managers to do that. So our nurse managers, nurse administrators, and school health already have between 25 and 40 employees that they're supervising. The fact that we continue to increase the number of nurses that we need for these community schools without increasing the number of managers has really created a lot of overwork. We currently have one nurse manager who's out on medical leave related to the stress of having to do all of this. They are waiting for help in trying to decrease the number of staff that they're supervising. We are going to ask for more nurse managers in the next budget for school health services, but these two will especially if we can hire them quickly, will alleviate some of the pressures that they have now. So all of these, so the 5 other positions that don't necessarily generate revenue will be paid for by the revenue generated by the others, but are equally important to the needs of our infrastructure across HHS.
Thank you. That's helpful. And it's sort of uniquely serendipitous that we're doing this along with GO, because GO has been doing such an outstanding job in helping the support of our Office of Human Resources, Department of General Services, as an example, acknowledging that internal public administrative infrastructure is critical for us to be able to carry out our work on the front lines. And this is yet another example of that. I'll also acknowledge that you did make this request as part of the fiscal year, and it was the council that did not honor that request. And that's why you are before us within the middle of the fiscal year to basically telling us, I told you so, for lack of a better term, as we go through the fiscal process. So I would certainly much prefer, all of us would, to have this more cleanly be attached to the fiscal year's budget process. However, we have to acknowledge that process is not perfect, and we do have immediate needs before us that is impacting the quality of the services that we are able to provide as a government. And if we don't provide those services well, it impacts our overall public health. You can draw a straight line. So I appreciate the request, understand the concerns of colleagues. I will, just speaking for myself, support this request, but I fully respect and understand if other colleagues have questions or concerns. I'll wait for other colleagues to ask questions, and then I will move that we support this request after those questions are asked.
Great. Thank you. I have Councilmember Friedson and then Katz.
Thank you. Appreciate it. My question really is about how you assess the generation of the positions themselves. We made an assertion here that these positions are going to generate revenue and the revenue will offset their costs. How do we determine that, and what is going to be the mechanism where you can come back to the council, and at what point to say, we told you so, to borrow a phrase from a colleague, and here's what it looks like? What do the receipts look like? Could you share that with us?
I think I'm understanding your question. So when looking at what positions were most important to us from an infrastructure perspective, we knew we couldn't just come and ask for 11 positions and hope that they get funded. So when we initially put this forward, we wanted to make sure that it paid for itself. And so we bumped up the revenue generating positions, knowing that with the positions we currently have, we can make this amount of money. If we add to that these 6 other positions, while we are getting MOUs and contracts with our Medicaid providers, that we can make an additional amount of money. It might actually be more than what we expect to be able to pay for these positions, but until we get into it, we won't know. So especially because we don't know right now how much more money we'll be getting from with those contracts that aren't currently in place. For the other positions, the 11 is not enough. I would love to be able to ask for 25 positions. I just couldn't pay for it with the revenues we're generating now. So we prioritized those other 5 in order to see what is the most dire need for HHS and for us to continue to provide the services across the board that we need to do. And so that was the decision that was made for why these particular 11 positions and why we switched out 2 because the nurse managers for school health became a higher priority over the last few months. So we expect that we'll be able to come back and say from our revenues that yes, indeed, with these positions, we increased our revenues by at least $1 million. We are putting some other things in place. We have 2 new coders, billing coders who we were working with them as contractors. We had to adjust the merit positions. They just weren't paying anything near market rate for other coders. So we just got approval for that to change those positions. And we'll now be able to hire professional coders, just like a hospital has or like a doctor's office might have, that can increase and make sure that the revenue we're generating or the claims that we're submitting and getting reimbursed for is maximized. We don't have a lot of subject matter expertise in our providers that we have now, especially our social workers who don't bill for services generally until they started working here, and then we did that for them. And so we're learning as we go. We're making a lot more money every year that we do this. We know that it's important for us to be sustainable, that we'll have to continue looking for ways to increase and maximize our reimbursements and to provide those services. Knowing that there are people who can't afford insurance or don't have insurance, that we as the safety net provider have to continue to provide. And so for us to be able to do that, we also need to find other funding sources. The state's going to cut our funding. The federal government's cutting funding in HIV, for example. So we have to find other revenue sources. And I think that by increasing our infrastructure, specifically related to billing for the medical services and behavioral health services, that's the place where we can make that happen. And we'll be happy to come back next year, sometime in the next fiscal year, to talk about the gains that we've made in that space.
I appreciate that. I'm going to ask 2 follow-ups. One, there are 2 different standards that are being discussed, and I just want to hone in on that a little bit. One is based on additional revenues that will be generated after these positions are in place, we will be able to cover these positions, to absorb the cost of these positions. That's one standard. There's another standard, which is what has been suggested. These positions in and of themselves will pay for themselves. Those are not the same things, those two things, and they're being talked about as if they're the same thing. And so I just want to hone in on which are we talking about. They're both reasonable things to say, and they're both reasonable things to expect, but they're 2 different things. To say these are 11 positions, these 11 positions are being put forward, and the revenue that they are specifically generated from these 11 positions will pay for themselves, as opposed to saying we're going to add these 11 positions, and based on the revenues we're collecting today and the revenues we expect to collect after the 11 positions are in place, we will be able to absorb the full cost of the 11 positions. I ask that because judging whether or not we were right and making sustainable financial decisions moving forward really depend on which one of those standards are the reality. And so I think we have to start now deciphering which of those 2 standards we are using and expecting, and then come back, and I want to talk about a specific time frame of what's reasonable to come back to say, okay, here are the receipts. Were we right or were we wrong? Was the standard that we set forth accurate, and are we going to make decisions accordingly? Because my view is, if you have 11 positions and in and of themselves they're going to pay for themselves, then why don't we do 25 positions as you want? Because if the positions pay for themselves, then what's the problem? If you're absorbing broader costs into broader revenues, that's a completely different standard, and then we have to be much more prudent and cautious about the additional positions that we bring online. So this impacts your ability to add positions, our appetite and willingness to do that from a fiscally responsible and prudent way. And so I just think we need to hone in on that. So that's question 1. I'd like a response. And then I want to talk next about what's the reasonable timing that we could come back and take a look and make thoughtful fiscal decisions for moving forward to make sure you're in a position to plan and to hire and to get things in place in time, and that we're in a position to actually, take up these decisions in a thoughtful way, on a cadence that is reflective of our standard budget process for moving forward, outside of this particular decision we're going to make today.
Sure. So these 11 positions, 6 of them revenue generating. The amount of money that we will increase in revenues is the amount I felt confident that we would get. And so, yes, I would love to ask for 25 positions. I don't feel confident that I could pay for all 25 of those with the revenue we're generating in this first tranche, for lack of a better term. So if after the first year we've seen that, yes, these 6 positions generated that amount of revenue, likely more, but we're surprised at the amount that we're actually making. And so now we're at $3 million, for an example. And so I can come back and say, look, yes, we were right. Having these positions does increase significantly the amount of revenue that we're generating. And if I continue to add more to these particular revenue generating positions, so more coders, more billers, more frontline staff to collect that information, I will feel much more comfortable sitting before you and asking for that, because then I have more data that shows that indeed creating these positions ended up generating revenue. And so that's...
Are you able to decipher by position both these 6 new ones that you're going to add if we approve what you have requested and the other revenue generating positions within the department? Are you able to break down by position, or at least by position type, exactly what revenues are being generated?
Somewhat. So I know that a social worker can bill for the services they're providing. So social worker is one of the positions that's here. 2 of the positions are front desk people. By having them, they're able to collect the information that's needed for billing the services. So they have time to now ask for insurance cards, and they now have time to enter all that data into the electronic health record, into our practice management system. So when it comes time to bill, that information is there. For the accountant that's in this request, there's an additional person now, will be an additional person who can then look at the claims that are occurring and find out why the rejections were happening, and fix those rejections and then resubmit them. Without these examples that I just gave, there isn't an accountant to look at the rejections, so the rejections just get written off. There isn't a social worker who's seeing more patients that we can now, or clients that we can now bill for. We don't have front desk people who are collecting the right information for us to be able to have everything we need to submit claims. And so it's difficult to say that a position will generate this amount of money. But I think altogether, in the way we thought about what was needed to be able to generate this additional $1 million to pay for this, is where we feel confident that we made the right choices. The other 5 positions that are not revenue generating are simply just infrastructure positions that are unlikely to generate revenue.
But it's about delivery of the services.
With our increasing services, right.
Okay, I want to clarify what has been shared. The 11 positions, 6 are revenue generating, intended to be revenue generated, 5 are not. The 6 that are revenue generating, the cost of those positions are expected to be absorbed by revenue increases, partially revenue increases that are the result of these positions, and partially just general revenue increases, because the department has done a good job recently with limited resources of increasing revenues over time, and you feel confident that they will be absorbed and have a net neutral budget impact. Is that fair to say?
Yes.
Okay. So I just think it's important to clarify, because they had been conflated a little bit about what we were actually saying, what we weren't. I would then strongly recommend, request that we come up with a mechanism. And, if you're not situated to do that now, then let's talk about the ability to do this moving forward and have a plan for it. But at the very least, the revenue generated by position type. So if a front desk person, if you can't do it by the individual, or a social worker by the individual, at least to say this type of social worker in this type of setting averages this type of revenue generation, so that when we make decisions moving forward, when you come to us and you request, you can say, these 6 position types, here's what on average, based on what we've seen, they generate, and here's what we expect them to generate moving forward. So it's not just us going on your expert opinion, which we very much value and tend to go along with because of your vast experience that you're comfortable with, and we appreciate your thoughtfulness and prudence in coming forward. But it's actually based on the data from the department of this is the exact position type, here's how much money it generates. And so that's why we can be confident. So that when we then turn to the public and say, why did we agree to this, and how do you know that it's going to be revenue neutral, we have something to lean on besides Mark's really smart. And we've got really great people working at HHS who told us so, because we need more than that to be able to get the trust of the public to be able to add positions, particularly when we're doing it outside of the regular budget process, which we all agree is not what any of us would prefer. So it's not going to stop and prevent my support of this particular item today, because I didn't ask you to do it, and we haven't asked you to do it previous, and that wouldn't be fair. But I do strongly urge you to do that moving forward, because it would make me, and I think all of us, much more comfortable moving forward to be able to lean on this and say, don't take any of our word for it, just look at the data. The data is pretty clear. Absolutely. And to have something to lean on to say that. In terms of coming back, second piece of this, and then I'll yield back and appreciate the indulgence of colleagues. What's a reasonable time frame to be able to look at this? Is it 6 months from now? Is it less? Is it more? But just for reasonable expectations of when we can come back, what would be a reasonable time frame to see if your projections were in fact right?
Yeah, so because we're going to prioritize getting the revenue-generating positions hired first, I think that's very reasonable to think we will have everybody in place by June. And so we will baseline where we are at that moment for reimbursements and collections. And then I think 6 months is very reasonable to come back and say, based on the baseline from July 1st, where we were collecting money, and now we should be able to see that we've collected, well, if we're going to do the math, we should be able to say we've collected $500,000 more, anticipating that these positions would generate $1 million.
So by
6 months,
January of next year, next calendar year, 12 months from now,
correct,
we would be able to look at the first 6 months of the fiscal year with these positions in place already.
Yep.
And then that would put us in a position for the following fiscal year to have the baseline to make decisions for your budget request and also for our ultimate decision. Okay.
Yes.
I think that's helpful. I think I would request that we plan on that and hold you to it. And with that and with appreciation, I'll yield back.
Thank you. And I think I'm just looking at the chair of HHS that you are in also agreement with that. All right. I have Councilmember Katz and then Licky.
Thank you very much, Madam Chair, Madam President. First off, thank you all for your work. And it always, I don't want to get that lost. And I thank my colleagues for many of their thoughtful statements and questions. I have often said, not just for this topic, but for many topics, it's a cruel joke if we ask you to do things and then don't give you the resources to do them. And that's not what we're talking about, is giving you the resources or having the resources. But I also believe it has to be mentioned, as much as people would like to say the government should work like a business, we're not a business. We're not a profit-making organization. It would be wonderful if we were. We're not. And in fact, some profit-making organizations, and we've proven lately, are not profit-making organizations either, and they had issues. But air profit is a very different thing. Air profit is to get people a better life for themselves and to get themselves in a better position. But I question, first off, whether or not you're comfortable that we could actually hire the people that we're looking for. We've seen instances in government lately that we're not able to hire the people that we need. Do you feel comfortable that we can do that?
Yes. The nice thing about infrastructure positions is they're not licensed professionals necessarily. They are accountants and secretaries and some of the other front desk type people that we're looking at hiring in this first 6 revenue generating positions. They're easy to hire. There's more people out there than registered nurses or licensed social workers. Those are the hard positions to fill right now. The fiscal type positions, we're not seeing lots of vacancies or a slowdown in being able to fill those vacancies. So I have 100% confidence that we can hire these positions.
And I guess to what Councilmember Friedson was discussing, if we come back, we find out we didn't get the revenue we thought we were going to get. I mean, everybody should think in a positive way, but there's also, the reality here. If we didn't, what happens at that point? You still need the social worker. You still need the people to get the better life. What happens if we bill the vendor and they don't pay us? What happens then? How are we doing? Do we have a plan B, I guess, is what I'm asking.
So the whole reason we're doing the MOUs and the contracts with the third-party payers, with the MCO providers, is to make sure that we do get reimbursed. Like I said, now when we submit claims, without that MOU, they deny all of our claims, and so we just write them off. As we become in-network providers, we are much more likely to get the standard reimbursement rates for all of those things. And because they're MCOs attached to Medicaid, there is a standard rate that we will be expected to receive for the specific services that we provide. Our coders that we have now are looking at maximizing all of those things. So if we hand out, for example, a no smoking brochure, we can get $26 reimbursed for that. And so who knew until the coders came in and said, you should do this. And so we started doing that. So having the right people talking about about billing and what we're supposed to be doing, very few of us, including myself, were ever in the billing world. While I was a nurse, I didn't bill for services or wasn't part of that. And certainly through my experience since implementing the electronic health record and doing the things that we're doing now, I feel like I have a lot more information and feel much more comfortable doing that. But I strongly believe that we will be getting the reimbursements from the third-party payers that we expect that we can't get now without those contracts.
Well, I am supportive. I hope I hope this plan works, but I also believe that if it doesn't, we have to have a plan to figure out what else we need to do in order to be able to provide the services that we necessarily need to provide. With that, thank you very much, Madam President.
Great. Councilmember Lukey.
Thank you. To add on to, and thank you for all of your responses thus far, and I know it's been tedious. And to add on to some of the things that Councilmember Friedson had asked for us to have a subsequent discussion on, and fully appreciating the complexity of medical billing, because it's its own universe. Like it is truly its own universe. But I note that you talked about if we don't have the MOU, you have to write it off. Like what have been the impediments to having and keeping current MOUs for these types of services?
So we were on a roll right before COVID hit, and we had a couple of MOUs that were going to be implemented any minute. And then as soon as COVID hit, we decided that other things were more important, and so they fell by the wayside. So when I started as the Chief Operating Officer for HHS a year ago, I wanted to start implementing that process again. And so we've identified a county attorney who has some experience. The county attorney's office is not filled with people who do medical billing or insurance contracts, but we have identified, they helped us identify at least one person who has some experience doing that. And so she's now working with us and the manager we have working in our practice management section of OCOO. And so we're now initiating them again. We are anticipating some pushback I know that MDH recently has put out a reminder to the local jurisdictions that they need to approve any contracts we have. We're looking into whether that applies to Montgomery County because it's generally associated with what the health officer is doing and the health officer signing those contracts. That's not what we do in Montgomery County. Our health officer doesn't sign those contracts, and so so there may be
there
some
a reason, like, how, could you explain? Could you unpack the why of that a little bit?
Oh,
like
sure.
Why it's different here than the other health officers for the other counties?
Right. So and why MDH might want to have them approve it, as health officers are generally employees of MDH.
Yes.
If they're going to sign an agreement, they want MDH to be able to
Correct.
to sign off on that. So that's the reason from that perspective. From Montgomery County's perspective, we have our own procurement system. We have our own contracting. The procurement director signs off on contracts. The director of HHS signs off on contracts, and then the vendor signs off on contracts. So for our purpose, it's the director of HHS who's signing the contract, not the health officer, who generally serves in any other public health department or office across the state. Where they would likely be the ones that are signing off on those contracts. Because of the way we're set up in Montgomery County and across HHS, the director is the one who signs those contracts. And so,
But the state allows us to do
the
that.
state, well, that's what we're waiting to find out.
Okay.
Because the whole purpose of that
Right.
Was, and Prince George's has said that they're kind of in the same boat. They do contracting differently than the rest of the state as well. But we have heard that other health officers have been concerned about the slowness of getting that done, and so
Sure.
we have our own ways of getting in our own way. We don't need the state to also be helping us do that. So we're trying to make this happen as quickly as possible. We're also going to follow up with the state to make sure that that's not a requirement. But we are pursuing those now.
Okay.
We do have a waiver. I worked on a waiver with the state insurance administration 13 years ago now, to get a waiver for the school-based health centers. So school-based health centers don't have to have a contract. We do get reimbursed for the services that are provided for Medicaid reimbursement at all of our school-based health centers because of that waiver. That doesn't apply to other parts of HHS or
Right,
public health.
right.
So that's the part where we need the MOU and the contracts.
And then have you, God bless you, have you done any, and there was lengthy questioning or comments about the types of positions and the functions they perform and things like that, right? Has there been ongoing auditing of like what the expected workflow is, what the actual workflow is for processing these types of claims and what the outcomes are? Meaning, are you assessing in any way where there might be either by type of claim or by, certain individuals processing them where there are more rejected claims, and how do we course correct that to fix those things moving forward, right? Sometimes it might be based on the types of services provided, like the social work context that you mentioned. Other times it might just be, not understanding a particular thing that's unique and quirky to the billing world. And so could you speak a little bit to that, towards how you assess the staffing model that you currently have, the one you're moving towards to maximize that revenue recoupment for services rendered, and be able to speak to that after approval of this when you come back to talk to us about what the net revenue actually is versus cost for engaging in the work.
Sure. So because we bill through our electronic health record, which happens to be NextGen at the moment, it helps us create reports. And so we know where the billing is coming from. We know which ones are getting reimbursed. We know when we've made enhancements to a process, like adding a no smoking brochure to someone's care, that we get increased revenue. We have really watched the process and assessed the process from beginning, from the collection of the card from the client at the beginning, all the way to either the accept or the reimbursement. The check comes in or it was rejected, and then we do a massive look at why that was rejected. Our most recent assessment, we realized that, and I don't blame anyone for doing this because it's the easiest way to do that, to mark things as non-billable. And so we have lots of employees who just mark it as non-billable because that usually it's one box and you don't have to collect any information or do anything as a result of that. So we fixed that. We've identified the programs, not necessarily the individuals, but the programs where that was happening most often. We've gone to their supervisor, we've gone to the chiefs and said, that's not acceptable. They need to do all this work. And so so we've gone back. The nice thing about billing insurance companies is many of them allow you to bill 6 months after the encounter.
Right.
And so we have gone back 6 months and started billing for those. We've fixed all of those problems. We have looked at when we get rejections, what is the reason for those rejections? We have a clearinghouse that goes from our electronic health record to the third-party payer. That clearinghouse also has some reports and helps us clean up some things before resubmitting them. And so we have done an in-depth look at where we could be making more money. We know that some of the positions that we're asking for and some of the positions that we would like to ask for in the future, more coders, for example, that they are for sure good bets for increasing our revenues. And so there's a lot more training that's happening. We just adjusted one of the IT positions to become a trainer, as opposed to hiring outside trainers. And so we can have somebody who's in-house who can do that all the time, who can assess where the need is and go talk to those individuals with those programs. It is something that Dr. Davis and I and Dr. Ashford as well have been discussing about improving our practice management, of placing a focus on that, of creating a more centralized billing system. Right now, it's the program's way out in different places, sending everything through the EHR to a fiscal, our fiscal department who looks at and sends it through the clearinghouse, and then a separate practice management who does quality assurance and the coding and everything. So being able to pull all of that together, which is our plan for the near future, should also help us improve that as well. So yes, we're constantly looking at making these improvements. It has been a priority for me since starting, that we are on the right track for doing this. Because I know, as a 23-year plus employee of the county, that for us to be sustainable, we're going to have to look for other revenue sources in a time where we are wondering where the next penny is going to come from. So
without that revenue generation coming back in, it makes it harder for us to do the vital work we actually need to get done. And you know, I'm glad you've spotted the challenges and the issues and that you're tackling them systemically. That's important, but it is disheartening to hear that people were just like, no, not billable. Right? Because they collect a paycheck no matter what, but it matters to the people out in the community who need the services, and it matters to us in terms of our fiscal responsibility and making sure we are wise stewards of that money and that we're maximizing the actual patient related services that we can deliver, and those types of behaviors are an impediment to that. So thank you for your oversight.
Absolutely.
Councilmember Sales?
I concur with my colleagues. I remember you raising this issue during one of our committee sessions previously, so I'm glad that there's a potential for already generating revenue with most of the positions, and look forward to updates on the report. So I support this. Thank you.
All right. I think everyone spoke, so I think this is without objection. We can move forward with this, and I very much appreciate your time going through all of this and getting this recommendation to the full council. So thank you again for your efforts, and appreciate and look forward to having you back when we do more budget work. So thank you. With that, that's our last item on our agenda today. This joint committee is adjourned. Thank you very much. Thanks.